I'm delighted to invite Rick Baird for his presentation. Rick is from University of Maryland, and he is the dean of the school, so any one of you who is interested in PhD programs should approach him later.
Good afternoon. Is that loud enough? Good. I'm supposed to hear back from you now. Good afternoon. All right, quick learners. Yes, I am Rick Barth. I'm privileged to be here thanks to Xarov Institute. And I am speaking today from my perspective as a dean. About 3 years ago, after about 30 years of doing research, I made a not very evidence-based decision to become the dean of a school of social work, and I have been trying since then to try to figure out how do we get evidence-based practice into social work education. One of the things I learned is that my presentations are always too long, so I start with my conclusions because I never get to the conclusion slide at the end, and these are my conclusions. That evidence-based practice needs to be based primarily on practice principles and common practice elements, not on manuals, even though I think Professor Gardner showed that manualized interventions can also be very effective. That increasing the uptake of evidence-based methods will best be achieved by increasing knowledge of common practice elements and common factors, and I will describe what those two things are later in my talk. And that adapting evidence-based practices to international context, as we are discussing today, may require emphasis particularly on common factors. So this topic of trying to describe and communicate about evidence-based practices has been going on a long time. I didn't have access to the Dead Sea Scrolls when I was back in Maryland, but I did have access to Anna Dawes' quote from 1883, which says, "What is needed, it seems to me, is some course of study where an intelligent young person," and that would be you, "can be taught the alphabet of charitable science." And we are still working on this alphabet of charitable science. Now, Aaron has given you a very good description of the alphabet of charitable science. It actually looks, before I decided to do this talk and kind of expand my thinking about charitable science, I would have described it this way, and I think this is, will repeat some of what Aaron said, and I think it's worth repeating, that evidence-based practice is, the top group here, is really about this framework of practice that integrates procedures and processes that result in the best research evidence with clinical experience and client values. But the conversation in the US in some ways has been more stuck on the second definition of evidence-supported interventions, and there are different ways of calling this, evidence-based practices or evidence-based treatments, evidence-supported interventions that are these manualized interventions. But then what I see in child welfare is that most of what we do is based on something we would call practice guidelines or practice principles, which are more a set of strategies or practice techniques that have fairly limited, there's usually some practice wisdom as evidence, but there isn't much more evidence than that. So what I'm trying to do today in this discussion, and this is a world premiere of this work, is to try to think a little bit more about the whole spectrum of ways that we guide practice and that we can teach about practice in social work education. And I'm going to go through this list. I realize the print is a little fine here, and try to talk through, and maybe the pyramid is better. The pyramid's a little lopsided, but maybe the pyramid is better. I'll work with the pyramid and go backwards. To talk about what we tend to do and I think what we need. At least in the United States, most of our education and training focuses on the bottom of this triangle in terms of guiding practice, which you may not be able to see, but it's basically our practice and policy framework. What is it that the law says we should do? What are the rules, even more than the law, that guide us? And then working up from that, sometimes we have practice principles. We have a set of ideas about roughly how this practice should go. And these would be a sense of how long it should last, as Professor Moss said, sort of how it should be focused with regard to its being very secure or being more open. We have these guidelines that often have relatively little evidence behind them, but they are the next step of implementing these practice principles. Then what I'm going to talk about is something that is fairly new in the American lexicon. It's called common factors. And these factors are generally described as three factors. One of them is that your practice is client-driven. Okay, you're using information from the clients. Sometimes we call it practice-based evidence, so it's client-driven. It is outcome-informed. You're checking in to see how you're doing with the outcomes, not just at the end, but on a regular basis. And the third is that there is a coherent treatment model. And that's the one that's the most controversial so far. And I can't say that there's yet strong evidence about it, but I will give you a little of that evidence. But it basically, the argument here for the common factors, from the common factors group, and there's a new book out called Heart and Soul of Change that describes this evidence pretty well, the second edition of it. And basically these common factors are supposed to be more dominant than what the treatment is itself. That if you check in with your clients, if you check out to see how they're doing, and you have a coherent treatment strategy, you are more likely to get a big impact than, or you are quite likely to get a positive impact. And it doesn't matter quite so much about what the intervention is in the middle. Now, a different perspective from that has been arising for the last 5 years or so from some scholars in the US who are working on something that is called common elements or common practice elements. And this goes beyond the common factors. It's saying it does matter what is in the treatment. It's not just the process around the treatment. It does matter. And that we have evidence now from randomized clinical trials that tells us what the practice components are that are likely to be the active ingredients. And this is what I'll spend most of the time in my talk about. Then there are these manualized programs, getting towards the top of the triangle. And we are having a growing number of these, and I think Professor Gardner did a nice job of talking about the ones in parenting. And there are many in other fields, in children's mental health especially. And this is, in some ways, what we have become focused on. These are these manualized programs. And then the top of the triangle is something I call specific knowledge of problems and solutions. And these are the things that we often go to trainings about. One of my areas is adoption and post-adoption services. And if I go to a post-adoption services training program, I'm going to learn all kinds of little things about the adoption triangle and attachment theory and these matters that are very specific about adoption. But my concern is that if we're really trying to train effective practitioners and we start at the top of the triangle with these very specific pieces of knowledge and we don't really talk about the common factors and the common elements, that we are not going to have the impact that we need to have. So one of my takeaway messages is that we work too much at the bottom of the triangle with the rules and the top of the triangle with the specific knowledge, and then we allow people to kind of fill in the middle. But there are some things now that I believe do fill in the middle. So let me give you a few examples of those, and this time instead of working up, I'm going to work down just to keep you alert. So these special competencies, one of the things that they can do is they can help you to engage people. So in the adoption example, if you do know about the adoption triangle and you do have adoption-sensitive language, adoptive families are going to be more likely to stay in treatment. Probably. We don't have strong evidence about that. But that is an important part of that. Whether the treatment's going to be effective, if that's all you're working with, I seriously doubt. And so far in the United States, we have zero evidence that our post-adoption services are effective after trying to provide some of that evidence for 20 years. Some of the evidence-supported programs, the ones that are now dominating our country and being transported the most, multi-systemic therapy and wraparound services and multidimensional treatment foster care. Now, these are programs they're not scripted in a manualized way, and I think this was also what Professor Gardner was talking about. They have a lot of discretion. They are broadly manualized, but those are important sort of general programs that address populations of concern. For example, children in foster care who would otherwise get into deeper trouble, adolescents, do well in multidimensional treatment foster care for adolescents. And then there are these more narrowly focused interventions and manuals, like trauma-focused CBT, Judy Cohen and Tony Manarino's manual. How many of you have heard of or seen any evidence of trauma-focused CBT here in Israel or elsewhere? Okay. So there's some knowledge of trauma-focused CBT. And it's based on a lot of pieces, a lot of components that I would call common practice elements that come out of working with people who have fears, like exposure to fearful stimuli, or people who have grief, like narrative therapy. And these are common elements that make up 5 or 6 or 7 or 8 different activities or exercises or skill training components that make up this overall manualized program, which in the US has done very well in randomized clinical trials to show that it helps children who have been sexually abused. The common elements that are coming out of this, which I'll spend more time on, are then the pieces that make up a manualized intervention or that make up a program, which would be like the list that was that Professor Gardner gave for parenting programs. They are general dimensions of programs, and then finally these concepts, the policy concepts like is safety the most important thing, or is family integrity the most important thing? And all of these together, if you master all of these things together, my sense is that you will have done you'll have a very good skill set around implementing evidence-based practices. The one thing I do want to say is that some of these manualized interventions, like the Incredible Years, which not only has common factors and common elements in it, but also has lots of different materials and videos and other things and experience and training, they may be more powerful standing alone than trying to assemble all this by taking a little bit of common factors and a little bit of common elements and some specific knowledge. So I'm not trying to argue that the manualized interventions are not as strong or stronger than some of these other approaches, but I'm trying to think more broadly about how we go forward in moving this forward. One of the things that we don't know at this point is what makes an evidence-based program work. There has been very little deconstruction about these programs, although I have confidence that for the most part they do work, like multidimensional treatment foster care. As I say, it has all these elements in it. And although there's some fidelity checking to see that they are used, this is not something that an individual can do. It has too many components, and it is really quite complex. So it builds on common elements, but it is much more than that. And in fact, if you wanted to try to implement multidimensional treatment foster care in your community, you would have to go to the developers of it at the Oregon Social Learning Center or the Center for Research to Practice, get paid for the whole package, get trained in the whole thing, go through fidelity measures. It's very complex to do that. On the other hand, if you can understand the elements of it, you could begin to try to build your own version of it, which you would then need to test. And I think Knut may talk a little bit about that, some of the work that they're doing in Sweden. The same is true about these more narrowly defined manualized interventions, like trauma-focused CBT. As I mentioned, it has these components, but we don't know which ones of them are really necessary. I know there's some work now going on in Seattle, for example, to take some of the elements out of the manuals to shorten the training so that not all of them are used. And the feeling is, no real science yet, practice wisdom, that the intervention is going just as well with a shorter group, smaller group of elements than what was originally designed by Judy Cohen and Tony Manarino. Okay. don't think I'm going to talk about that. So one of the big issues in trying to figure out how do we implement evidence-based practice is if we know these manuals work, we should use them, right? Well, yes, but there are now hundreds and hundreds of trials that demonstrate that one program is better than treatment as usual or something that's a little more than treatment as usual. And if you're a graduate student these days, you have to ask yourself, okay, which of these evidence-based practices do I learn? And which of these manuals do I practice so that I have mastery of? And then you have to hope that the right clients show up so that you can use these manuals with those clients. Okay. So the alternative approach that is, I think, now coming into more attention in the US, there are some doubters because there's only one still unpublished randomized clinical trial that demonstrates the effectiveness of this, and I'll say a little bit more about that later. But the concept is that you continue your emphasis on evidence-based treatments. This is not a movement away from evidence-based treatments. You continue to tell people that they should develop manualized interventions because that is the best way to figure out what overall packages seem to make a difference. And the field continues to do those to a certain extent, whether you want them to or not. And then you deal with the information overload. And the way that Bruce Chorpita and his colleagues have done that is they have looked at these trials, hundreds of them now. My slides cannot keep up to date because they're coding them all the time from all over the world. I think more than 400 trials where there was an effective group. There was a group that had an effect size that was significantly greater than the treatment as usual. And they peek into those manuals and they code those manuals. They collect them. They get them from dissertations. They get them from big studies. And they figure out what are the components. As someone who has developed some manualized interventions, I can tell you that when I developed mine, I was looking around at other manuals too to steal what I could from other people, these elements, and to stick them into my program based on a loose logic model about what would work. And so what they're doing is kind of reverse engineering. Instead of grabbing them to put them into a manual, they're saying, let's go to the manuals and separate out the elements. So it's the actual treatment elements that become the unit of analysis rather than the treatment manual. And they have created a website where they have all these treatment elements and they have the characteristics of the study population, so they know how many, was it mostly males, was it mostly Native American children, what were the characteristics and so on, and how do these elements seem to fare with these different populations. And they first coded 322 randomized controlled trials to do this. They estimated that $500 million had been invested in these studies over 40 years with 30,000 youth in them. And they asked these questions: what makes up these successful manualized interventions? What are the common elements? They looked to see what were the most common practice elements. They identified 41 of them that are in these interventions that were in at least 3 of the winning treatment groups, and they have now created training materials that are that represent 29 of these practice elements, and that's where they are now. They're looking to identify more of them. Most of these trials were in the area of children's mental health. So that it doesn't necessarily map so clearly onto child abuse prevention, although I think the argument can be made, and there's some data from the PPP study, for example, which is, PPP was also designed to affect children's mental health, that if you improve parenting and children's mental health, or you just improve children's mental health, that you are also likely to reduce the risk of child maltreatment. So what they then did is they said, okay, well, these are just the elements. We also need to have this process. And they don't call it common factors, but it is, in fact, a program that allows for not only the selection of the elements by having this database that says, okay, I've got a 12-year-old female who is anxious and depressed. What research do we have that matches up elements of successful interventions with 12-year-old anxious girls? What elements match up with effective interventions with 12-year-old depressed girls, and then they have a set of possible elements. So they put all that data onto the website, and they've developed a modularized approach to this. So what they then did is they put a group of experts together, and they said, okay, what if we have a dually diagnosed 12-year-old female who has anxiety and depression? Which of these skills should we use first? Should we use behavioral activation to reduce the depression? Should we use psychoeducation as a strategy? Should we use exposure to try to reduce the anxiety or the fearfulness? And so they've come up with an algorithm that helps to sort, to order these elements in a reasonable way. But we don't have any science about that. None of these manuals have been deconstructed to tell us which order things should, we don't have any hard science about that. We don't know which order these elements should go in. But the match protocol that was tested in this $5 million randomized clinical trial by MacArthur with kids who had conduct problems, depression, or anxiety showed that it was more effective than the manualized intervention. So they taught all these therapists these manualized interventions and also these common element strategies using this matching algorithm. And then they also had a treatment as usual condition. And the common elements approach did significantly better in helping these children than either the manualized interventions, the specific manualized interventions, or the treatment as usual. Now, it's just one study. It still hasn't passed peer review. There was a big hoopla about it in the children's mental health community. I think it will end up being published and will be considered a landmark study, but that is still ahead of us. These are some of the kinds of skills that are in the list of 29. You will recognize these as primarily cognitive behavioral skills. But there could be other skills that are added as well, or practice. I shouldn't call them skills. These are actually practice elements or common elements. In the U.S., we are now in the middle of a project to expose social work faculty to these ideas. We had a summer session last year with Bruce Chorpita with about 25 faculty there to learn the ideas. People are trying to take these concepts back because of the recognition that trying to get full manualized treatment approaches into social work curriculum or even into agencies is very difficult. But that if you can teach a handful or a dozen or maybe all 29 of the elements and help people to use them intelligently, you can do that in an easier fashion. That's at least the concept. We have no proof of the concept yet. This is just an example. You can't see it, but I'll encourage users to go to their website and get an example of the kind of way that they describe their elements. So they have 2 to 4 pages about how to implement things like activity selection, which is a strategy for helping people who are depressed to find activities that will be rewarding, because being rewarded is the countervailing force to depression. So those are just some examples. The other thing I think that's very important, and this is where the common factors, I'm switching now from common elements to common factors. This is where the common factors piece comes in, is that they are not just teaching the elements, but they're also teaching clinicians to say, this is what problem I'm working on, and many of us are not always that clear about what problem we're working on, and this is the element that I'm using to address this problem, and there may be more than one, and this is how it's going. So what this builds in is the common factors of checking in and keeping track, or at least the common factor of being outcome informed. And there's also an element of client driven in here, but being outcome informed and changing your practice. If you picked activity selection as the first intervention for that 12-year-old and it didn't seem to work, after a few weeks you want to know that it's run its course, and then you want to switch to something else. So that's how this works. So I'm switching now to more discussion about the common factors. I already mentioned what they are: feedback from clients on their level of functioning, feedback to the therapists on the therapeutic alliance. That's part of the checking out, and I'll show you some of the questions that get asked by the therapists. And then this coherent treatment approach. And the last part is the most debatable part. There are some dyed-in-the-wool behaviorists who say, no way could a psychodynamic treatment put in the bookcase between these bookends of checking in and checking out really be as effective as CBT. And of course, there's some others who would say, well, CBT isn't that effective. It's really, a psychodynamic intervention. That part of the debate is still not clear. But what is clear is that there is, I'm sorry, I'm going to move through this a little quickly. There's one study. Well, let me show you this. So this helps a little bit because I'm running short of time. This is the adult measure. At the beginning of every treatment session, they ask these 4 questions, and at the end of every treatment session, they ask them, how are you doing personally? How are you doing interpersonally? How are you doing socially? And how are you doing overall? And they literally just take the cursor on the computer and mark a space on this line, or they take a pencil and mark it. And then it creates a conversation that they use. There's a child version now that's been developed. How am I doing? How are things in your family, your school, everything? And these kinds of questions, just 4 questions, are becoming what is considered to be best practice now in children's mental health. Sometimes they're called a measurement feedback system, but basically the idea is that it's very important to know as you're going along what's going on. So when you have a manualized intervention, or if you're using common elements, you can continue to adjust your intervention. So these are what the measurement feedback systems are. They are short, they are psychometrically sound, and they're useful in everyday practice. And this is the core of this common factors aspect. The ones that are being developed now don't just ask about your, for example, your feelings of depression, but they ask how you're operating in different domains of your world, in your school, in your family, in a child's case, with your peers, with yourself, in the neighborhood, for example, those kinds of dimensions. And they also, and there is at least some evidence that they do make a difference. The best study so far done with this, with adults, is a clinical trial in Norway with couples where they used these techniques with an RCT, randomized clinical trial, and they showed that even if you don't train the therapist to do anything differently, if you just get them to use these checking in and checking out, they had a very good effect size. This was an intent to treat study, but they did have more retention in the treatment group because this improves the alliance and it improves the client's sense that they are cared about and that the treatment is being adjusted to meet their needs. So we can call this common factors, we can call it practice-based evidence, but it is an important complement. It appears to, the new evidence appears to be suggesting to the other parts of evidence-based practice. I just mentioned this study, so I won't talk about it again. The other thing I want to mention is that some of these strategies that are being used in multidimensional treatment, foster care, for example, are much more specific than that, and you actually call families and get information from them on a daily or weekly basis using a parent daily report, and that's a form of this measurement feedback system. It may be one of the most important active ingredients why some of our programs like multidimensional treatment foster care are working. We don't know yet, only time will tell, but thank you for giving me the opportunity to pose these possibilities to you.